Good afternoon and welcome. Welcome to the Wilson Center. I'm sorry it's so cold in this room. Unfortunately, we have no control over the air conditioning, but we're trying to get them to adjust it. It's the entire building. So if you need to get up and stretch and warm up a little bit, please do so. But I'm sorry it's a little chilly in the room, but the conversation will warm things up. So welcome, I'm Roger Mark D'Souza. I direct our programs on global sustainability and resilience here at the Wilson Center. And this includes our maternal health initiative. I think many of you are familiar with the Wilson Center. We serve as the living memorial to President Wilson. We're a think tank, a major convener. We've been recently recognized as the #1 think tank globally for international interdisciplinary research. And the work that we do on maternal health is very much part of that work because we look at how we connect maternal health to other strategic sectors. Our conversation today is part of our maternal health initiative series, which we do in collaboration with our maternal health task force colleagues at Harvard. We have our colleague Katie Millar and others here with us. Welcome, thank you. And the United Nations Population Fund, Gita Lal, has been our point of contact with UNFPA and a major collaborator for us. And we really focus on how we can showcase innovative research and best practices, synthesizing and sharing policy-relevant insights to scale up solutions for improved maternal health. And when we look at the maternal health landscape, we know that globally we've made strides in improving maternal health. We know that the number of maternal health deaths globally are going down, but we know that far too many women continue to die from preventable morbidities. So we recognize this context. We recognize that there are urgent situations where there are opportunities to intervene right now. And we know when we look at some of the figures coming from WHO that maternal mortality is highest among the most disadvantaged women. So we're paying attention to these statistics and trying to think a little bit more about what it means for us in this community as we seek to engage and have conversations about what's happening programmatically and what are the policy options. We know that we've been looking at this and tracking this in the context of the Millennium Development Goals, the MDGs, and now the SDGs, the Sustainable Development Goals. And we've been looking at SDG 3, which is, as many of you know, working to ensure the healthy lives and promote the well-being for all at all ages, and has an ambitious and urgently necessary goal of reducing the global maternal mortality ratio. So that's the context in which we're having this conversation. We recall that in October last year, there was a very significant global maternal newborn health conference in Mexico City. We recognize the importance of our convening at that meeting, and subsequent to that meeting, we met here in April of this year to look at what happened in Mexico City, what were the challenges, what were the opportunities, and what it means moving forward. During our discussion, we specifically looked at questions around integration, quality, and equity, which we saw as keys to accelerating progress towards SDG 3. So to keep that conversation going, as we typically do, we had an event summary for that event that we did in April 2016, and we were teeing up for the conversation to happen in Women Deliver in Copenhagen. So now this is an opportunity for us to recognize and embrace that context, think about the dialogues and discussions coming out of Mexico, and reflect on what has happened at Copenhagen and what it means moving forward, specifically bearing in mind the SDGs. So after Copenhagen, what's next for women and girls? And I'm really delighted to have three excellent colleagues here with us today to give us a sense of their perspectives from the conversation in Copenhagen and what it means moving forward. So we're going to start with Susan. Susan Papp is the Director of Policy and Advocacy at Women Deliver. She was a vice president at Rayburn Martin, where she supported the advocacy and communications efforts for Merck for Mothers. And she's also worked with the White Ribbon Alliance for Safe Motherhood in India, where she evaluated social accountability programs to improve maternal health. She's also served as the vice president at GMMB, where she directed advocacy, branding, and communication campaigns. So Susan, welcome. I hand it over to you.
Thank you, Roger Mark, for the introduction. It's great to be here today with all of you here in Washington. I spent many years in Washington before moving up to New York, and I always love coming back down here. It's like coming home. Before we get started today, I'd like to ask people in the room, how many of you, show of hands, how many of you have been to a Women Deliver conference before? And how many of you were with us in Copenhagen? Okay, great. So it just helps me understand the audience and what I'll be sharing with you. So I think this is how it works. Great. Women Deliver, for those of you who are less familiar with our organization, we're a global advocate focused on the health, rights, and well-being of girls and women. And we operate at a global level, influencing the agenda. We did an external evaluation a couple of years ago, and we were recognized for 4 things, and we call them the 4 C's. Convening and connecting is the first sort of paired up C. Communicating, capacity building, and catalyzing. And we do this with civil society organizations, UN agencies, and we also bridge across to the private sector to help make meaningful change for girls and women. Our conferences, this conference that we had in Copenhagen was our 4th global conference, and we've become known for really renowned civil society-led global convenings. And the conference in Copenhagen was the largest conference that we've had yet, and it came at a symbolic 9 months after the adoption of the SDGs. And as we were thinking about planning and what the agenda and program would look like, we realized that we needed to make the SDGs the focus. And we needed to think about all of the many challenges and opportunities that the global health and international community face now in the wake of the Sustainable Development Goals in this new era. Everyone's sort of scratching their heads. It's no longer business as usual. It's much more complicated than thinking about MDG 5. And it's much more complicated, frankly, than thinking about SDG 3. If we only focus on SDG 3 as a way of reducing maternal health and improving SRHR, we're not going to achieve our goals. And so we at Women Deliver wanted to create a program for all of the participants to look at the interlinkages between maternal health, sexual and reproductive health and rights, and things like education, cross-cutting things like poverty reduction, WASH. And so in formulating the agenda, we did that. We tried to be much more bold and broad in our offerings to the participants. So the focus of the conference was really, how do we implement the SDGs so they matter most for girls and women? And we looked at the health lens, but also the cross-cutting lenses and the interconnections, particularly around gender equality. The conference was really meant to be a fueling station and a place for inspiration for everyone who came and joined us in Copenhagen. And we don't really frame ourselves as a traditional technical conference. These are advocacy conferences. They're upbeat, they're high energy. We want to make sure that people are in a room talking to people that they're not, accustomed to seeing at other global conferences. And we want to be able to put solutions front and center. We as a community know what the challenges are before us. We've spent decades and decades evaluating those challenges, and now we need to move beyond that and think about action and solutions, and that was really the focus of the conference here. Over the span of the conference, we hosted more than 200 sessions and side events that explored those solutions, but not only the solutions, but how investment in the health rights and well-being of women and girls can really power progress for all, particularly in this new development agenda. And we really feel like since the global development paradigm has changed, we need to change the conversation, and Women Deliver is happy to help move the community along that spectrum of moving the conversation. We brought together world leaders, advocates, civil society, academia, decision makers, policymakers, the private sector, to talk about the state of girls and women and why it's important to invest in them and why they need to be at the center of any global development efforts. And you'll see on the screen here, we had many notable world leaders. Melinda Gates came and talked about a new data project that an investment that she and the Gates Foundation are making to fill the data gender gap so that we can make more informed decisions about investments in girls and women and better understand their lives. And we, along the spectrum of all of the program offerings, we broke it into 14 areas. So for those who've come to Women Deliver conferences in the past, you're really accustomed to very heavy focus on maternal health and sexual health and rights. And we broke the mold and went even as far as talking about sports. And we had the International Olympic Committee there and FIFA there to talk about how when girls and women have the opportunity to exercise their leadership and negotiating power on the field, it really translates to big wins off the field. So this is just a quick overview of how many participants came. It was our largest conference yet, almost 6,000 people from 169 countries. And I'm really happy to say that our 169th country was Saudi Arabia. And we were really, really thrilled to see that. We had more than 2,500 organizations represented, and we had 81% of the participants had never been to a Women Deliver conference before. And that's probably the number we're most proud of, because we feel like it's important to keep engaging new audiences and broaden the audience and not talk to the usual suspect. And so this was a real nice demonstration of that. Youth was also a big priority for us. And we had 20% of the participants were under the age of 30. That's how we define youth. And we gave out scholarships to many of those young people. 40% of our operating budget for the conference goes to scholarships, and the largest scholarships recipients are under the age of 40. And we also had really exciting exhibitions. In addition to sort of the general program, we also wanted to be able to have some auxiliary offerings. And so in this top corner here, you'll see some of the youth in yellow who were with us in Copenhagen. We had a 2-day youth pre-conference, and they talked about advocacy training and did advocacy workshops and communications workshops. They also talked about very timely topics on the agenda and things that are underrepresented in the Sustainable Development Goals. And the targets like comprehensive sexuality education and how they can get that on the agenda more prominently. And we also had for our first ever Appy Hour, which is a picture of that is in the top right corner, where we brought together 10 innovative app designers who were able to profile their work. And one example of that is the Maternity Foundation profiled a job aid program that they have, an app that helps health workers with obstetric emergencies and newborn care. And then in this bottom quadrant here on the left, it's an example of the Social Enterprise Challenge that we hosted. And we hosted the Social Enterprise Challenge with Echoing Green. And we wanted to be able to use the Social Enterprise Challenge to be able to highlight the interlinkages between women's health and other things like the environment and political voice. And the winner of the Social Enterprise Challenge was a small enterprise called Green Char. It's based in Kenya, and they formulate briquettes that are smokeless briquettes to help women and families with cooking, a smokeless form of cooking inside their homes. Many of you may know that 4 million women and children die prematurely because of indoor pollution. And so an innovation like Green Char can really help address a lot of the major challenges affecting women and children. And then the last photo there on the bottom right is a sample from our ministerial forum. And the ministerial forum this year was co-organized by friends of ours at UNFPA, the Danish Foreign Ministry, and UN Women. And it was the first time, it wasn't our first ministerial pre-conference, but it was the first time we had ministers beyond the health sector. So we brought together gender ministers, education ministers, finance ministers, foreign ministers, and health ministers to talk about what policy coherence looks like in the sustainable development era, which was a really, really tremendous step forward. Here's an example of some of the ways in which Women Delivers convenings try to forge networks. So I mentioned the ministerial forum, but in addition to the ministerial forum, we also had a parliamentary forum. We had more parliamentary representatives than we've ever had before, coming from 54 countries. We had our first ever private sector pre-conference, and the private sector pre-conference brought together large multinational corporations like Philips and General Electric and Novo Nordisk and others to talk about, and small companies at the same time, to talk about how to make investments in your value chain and how to improve the lives of girls and women along the value chain and how to think about that in the context of the SDGs. As many of you have seen, when the private sector really thinks about closing the gender gap, it can really have tremendous dividends. The McKinsey Global Institute recently came out with a study that showed if you're able to advance women's equality, it could add an additional $12 trillion to the global GDP by 2025, which is a huge, huge finding. And we talked about what that looks like and how do you translate an aspiration like that into practice. And then we also worked with PATH to co-host 8 regional caucuses. And the regional caucuses were an opportunity to bring people together at the end on the last day of the conference to talk about what they had learned over the course of the 3 days and how that they could translate those learnings and those findings into policy and practice at the country and regional level. So another big way in which Women Deliver 2016 was innovative was the fact that we tried to reach beyond the walls of the Bella Center in Copenhagen. And we pioneered womendeliverlive.org, and it was almost like going, when I first went in during the walkthrough the day before the conference started, I felt like I was at Ohio State, where I grew up right down the street. There was like a big ESPN studio where we had live coverage of participants from the conference, streaming for multiple hours a day, content of the speakers, recaps of sessions, live streaming concurrents. It was really remarkable, and we wanted to be able to open the door to the world so that those who couldn't join us in Copenhagen could be there and still participate. And it sparked a really wonderful dialogue, and there were more than 30 watch parties around the globe. And some of the numbers really speak for themselves in terms of the reach beyond the Bella Center. So all of the social media posts, the Twitter following, we had more than almost 2 billion Twitter impressions from the conference. We generated a number of news stories in many countries, and we were able to have the viewers tap into Women Deliver Live and really follow the conversation, but also contribute to the conversation because there was a parallel track on social media. So where do we go from here? where we go from here at Women Deliver, one of the things that we want to be able to contribute to the community is we're developing a solutions panorama. And the solutions panorama is a compilation of 100 of the solutions, 100 plus solutions that were touched upon at in the plenary sessions and the concurrent sessions. And we want to be able to put them all together so that it can be a resource for the global development and maternal health and global health communities. And we want it to be a tool to foster knowledge exchange. We want it to be a resource so that participants who are both with us in Copenhagen but also with us online can go home and really take up the ideas and the best practices and put them to work. We really, much more boldly than we have in years past, and we're pretty bold in years past, we are issuing a charge to the participants to go home and roll up their sleeves and make sure that girls and women are positioned solidly on the agendas, and in places where they already are solidly on the agenda in the implementation of the SDGs, that they stay on the agenda, that it's not just a tokenistic mention of girls and women in those agendas. And we're also issuing a challenge to participants to start to tease out some of those solutions and test them. So when you come back to Women Deliver 2019, we can see how things have gone. Another area that we are embarking on to really continue the momentum from the conference is a new campaign that Women Deliver and partners launched called Deliver for Good. And it's a new communications and advocacy platform that we've spent the better part of a year organizing. It applies a gender lens to the Sustainable Development Goals, and it goes well beyond SDGs 3 and 5, but is meant to highlight the interlinkages of issues and the interlinkages of investment. So the ripple effect that takes place when you invest in girls and women, whether that's making sure that you're investing in comprehensive sexuality education and how that ripples out into reducing gender-based violence and reducing maternal mortality and giving girls more negotiating power, to something a little bit more of a head scratcher for people in this community, like giving women political voice. And so here's an example of a briefing pack that we developed. We have online briefs that were open for consultation. We'll be reissuing those briefs during the UN General Assembly this September. And we have infographics, sort of a cheat sheet that decision makers and influencers can use as they're thinking through the policy and programming recommendations. And they also have political asks on the back. So what you would ask as an advocate of your decision makers. We'll be adapting these as the program and campaign evolves to country contexts. And we really look forward to engaging all of you in this campaign. So far, we've had 150 organizations sign up for it. So really coming to the end here, investments in girls power progress for all. And we hope that you got that resounding message from us in Copenhagen. We really see gender equality not as the finish line, but as the starting gate. And it's the starting gate for so many of the development challenges and priorities that we as a community face. So I look forward to continuing the discussion and fielding your questions throughout the rest of the session today. Thank you very much.
Thank you very much, Susan, and congratulations. Wow, there's a lot. There is a lot there. And as I look at some of the materials that you had developed around the Women Deliver, and you look at some of the materials around Deliver for Good, there's a statement here that I want to ask you to talk a little bit about. She doesn't know what I'm going to say. She's like, what are you going to ask me? So you say girls and women carry more than babies or water. They carry families. They carry businesses. And I want you to talk a little bit more about that last phrase, because in your presentation, you talk about engaging the private sector. And I know some of the documents that you have developed are focused on developing the investment case You're making the case for investment. What is the case for investment for businesses?
Well, the case for investment for businesses is really, it almost sounds glib, but women are consumers, they're producers, they're reproducers, and they constitute the world's largest emerging market that's bigger than India and China. And when you fail to recognize their power, both as active participants in a market-based economy, when their needs are visible, when they have unpaid care work that really, the level of unpaid paid care work is really staggering, and it's a number that we don't really know that much about. That's one of the reasons why Melinda Gates is so keen to invest in covering this data gap, or closing this data gap rather. You have so much untapped potential and undercounted potential of women and girls. And those are some of the things that Deliver for Good hopes to uncover. And it's a cross-cutting partnership with the Global Partnership for Education, groups like Landesa, and others, so that you can see how women and girls contribute to their families, their communities, and also their nations.
Great, thank you. So the data piece is still important for advocacy. Thank you. I'd like to move on to our next speaker. Dr. Mary Namambao is a public health specialist working as a deputy director of Mother Health in the Zambian Ministry of Health. At the national level, she's the advisor to senior management in adolescent health, family planning, safe motherhood, sexual and gender-based violence, cervical cancer, and fistula management. Wow, so you're covering a lot. Having facilitated the launch of the campaign on accelerated reduction of maternal, newborn, and child mortality, CARMA in Zambia, her vision is to never have women die while giving life. Mary?
Good afternoon. Yeah, when it's put like that, I feel maybe my peers should increase my salary. Yeah, I wanted to say something. This was my second women deliver. I went for the one in Malaysia, and those who were there, you remember that Zambia came with the First Lady. So you can imagine the type of running around we did. Yeah, so when I went for this one in Denmark, I was supposed to go with the Minister of Health. But because we are having elections this year, he couldn't travel. So I went with someone who was even not as high as, okay, she was a bit lower. So you can imagine how much fun I had. So when I was told to come here and sit on the panel, I knew, I said, okay, so that was the catch. It was too good to be true. So the previous speaker mentioned something about booths, so that's the first one you're seeing there. I think I've never enjoyed going through the booths the way I did in Denmark. I think this was the richest exhibition we had, including other workshops I've attended. Those who were there, you remember this? And I thought it was nice. After each session, I don't know what you call these people, but they would summarize the sessions, and then they would put them where we can find them. I just thought I should show off. Yeah, so before I explain what Zambia learned from Women Deliver and how we are working with other ministries, I thought you should understand our situation. Before we started the MDGs, we were, I think, around 600 and something per 100,000 live births in MMR. Then we went up to 792. And then we had to, this was, sorry, I can't see, around 2010 when we did the Kama campaign and all that, our strategies were very enhanced. So we kept coming down. We are now at 398. Then after we went to, we had that meeting in Mexico, and then we had the women deliver, we started trying to domesticate the SDGs. So for Zambia, we said, okay, what we'll do is this year we are revising our NHSP, that's the National Health Strategic Plan. So we gave ourselves a target and said we'll go to 166 in the next 5 years, but we wanted to go to 50 by 2030. I know it's tough, but this is something we've agreed upon with the partners, stakeholders, and the policymakers. We hope we can do it. This was where it was before. Those of you who had Zambia present before, we used to have about more than 40% of the women who died at home, and then would have the others die at the facility and a few die along the way. But because if you saw the way we are bringing down the maternal mortality ratio, there were strategies we put in place, especially for us, KAMA, we took it very seriously. It was something which was there in all the stakeholders. It's like we moved the people from delivering at home, they're still delivering at home, but most of them would go to the facilities and deliver there. But the problem was then they would still die. So you find that all those who were dying at home are now dying at the facility. And then the other problem we have is we have a problem with early marriages. Those are different provinces. We wanted to disaggregate so that you see, but you can see the average for Zambia. It's like most of our women are married below 19 years old, some of them even 17, and that's across the whole nation. So when we launched the campaign to end early marriages, it's because for us it's a big problem. Those are teenage pregnancies. You find that we have almost all the average for Zambia is about 25% or so, but you find that we have provinces or what you call states which go up to 40, 35% of all pregnancies are teenage pregnancies. This is the saddest slide, I think. Every year we look at those girls who dropped out of school due to pregnancy. We know that it means all these are unplanned, unwanted pregnancy because you can't want to be pregnant when you're in school. So it's like we reduce, we are not even sure if it was a real reduction. Maybe we're not just vigorous enough in trying to get the data. But again, we've gone to about 16,500 girls per year. I was arguing, I said, are you sure this is not accumulative? They brought the data to me and I discovered it's not actually accumulative. Next. Yes, so what is it we learned from Women Deliver when we look at our situation? What were we interested in? So for us, we went there to look at how can we be more accountable over the maternal deaths beyond the routine MDSR. We do a lot of maternal deaths. You looked at the first slide where I showed that our women are now dying in the facilities when they used to die in the homes. It's because we have a very vigorous system to look at the maternal deaths, although we haven't moved to confidential inquiries yet. So what we said was, can we try and establish a real-time electronic maternal death notification system? The way it is now, we do notifications, but they'll just come whenever someone can pass them on. Then they would reach our office. Then we'll do a report. Maybe once in a quarter, we'll report to the PS. But from after Women Deliver, we thought, no, we need to make this electronic so that immediately that maternal death occurs, Vice President would know about it. The other thing is we had, as I'm talking now, we've already engaged the consultant. We want to move to confidential inquiries and also review the near misses and the stillbirths. Then we also want to scale up. We have community dashboards where the community themselves, they will know the population, they know the women who got pregnant, the girls who dropped out of school and all that. So we just want to bring that one up. And of course, to the involvement of line ministries as well as the private sector in the maternal death and surveillance things. This is one of the things we've done. We have a scorecard, and we're using the ALMA platform, those of you who know it. Wherever you see green, it means we are doing fine. Red, we are not doing fine. Yellow, we are trying. I'll just mention maybe 3 indicators which are there. The first row where you see green, it's like we've had problems coming up with indicators to monitor adolescent health in our HMIS. So what we've done is we've looked at how many girls are coming for antenatal who are below 18%. So we've put a threshold. Below a certain threshold, you get green. For Zambia, it can work because our first antenatal visit is very high. It's about 90%, meaning almost everyone goes for first antenatal. But if you don't have such a high percentage for first ANC, you can't say you're monitoring the adolescents. So I don't know. I hope after this I can go back with an indicator which will be sensitive to adolescents. The other one I wanted you to look at is the third one, which is red or red. That's how many women are coming for antenatal in the first trimester. Remember, I've told you they come once, we are 90%, but to come in the first trimester, to come early enough, we are below even 20%. Next, please. So the situation analysis I showed you, you could see we have a big problem with adolescent health with the young people. So there was this thematic group which said investing in women and girls for everybody to win and end poverty. How can we all work together to end teenage pregnancy, child marriages, and school dropouts due to pregnancy? Partnerships with line ministries. I'll just mention a few. This is something we are already doing, but I feel we could have done it better. I saw that slide where there were a lot of ministers from Ministry of Gender, Finance, and all the others. If only our ministers had come as well, because I think for Zambia we need all the line ministries to work together. I heard there's UNFPA here. I don't know, I hope you can talk to our country office UNFPA because they didn't seem to be passionate over it. And those are the people who the politicians will listen to. If I had to go and plead with my minister to say, can we go for women deliver? But if the UN also can come on board and say we need other ministers to go, I think it will work better. So you find that we have Ministry of Education, Ministry of Youth and Sport, and these, we are working with them to scan up the comprehensive sexuality education. This we are doing with UNESCO. We also have the out-of-school comprehensive sexuality education. And on this one, I'll give credit also to UNFPA. UNFPA is helping us a lot. The other thing we are trying to do is we launched a campaign ending child marriages with Ministry of Tradition, Chiefs and Tradition Affairs. Now the campaign has moved to Ministry of Gender. Then we have Ministry of Community Development, which deals with vulnerable children, especially girls, and then Ministry of Health and Ministry of Education. So all these are working together to try and end child marriage. But for Ministry of Education, they've gone a step further also to bring back the girls. We are calling it re-entry school policy. So all those girls I showed you drop out of school because they are pregnant. They can always go back. But you and I know because of poverty, even if we have that policy, if we don't deal with the grassroots causes, they still won't go back. Or if they go back, they won't go and stay. Then we also have something we are trying out with UNICEF and then with Ministry of Community Development and Social Welfare. This is integration of social cash transfer with sexuality, reproductive health. So we are trying to, this is a ministry which goes and identifies the vulnerable children, adolescents inclusive. So we try and go with them, and as they are doing that, we ride on that platform and we bring in the services for sexuality education and where we can even the commodities, information and the like. Next. So what were the other cross-cutting issues we learned from Women Deliver? I was so excited, and I think I talked to a lot of people. That's how come you saw me in those booths. I would go back every day. If you were there, you saw me all the time near the people talking about menstrual hygiene and management. I think there were two things which we've been silent about all the time: stillbirth and MSM. Okay, MHM, sorry. This menstrual hygiene management, no one was talking about it. We'll talk about a lot of things about what the girls need, but not what really they want to talk about even to their parents and their peers. So this Women Deliver brought that one out. We had a lot of booths where they were even showing us, because I was telling them there are different kind of booths. Some were talking about high-level menstrual pads. The others were talking about locally made. So I explained to them, I said, no, for us we need locally made because they can't afford these other ones. And they had that, and they had the samples. So when I got back, I engaged our colleagues from Ministry of Education, Ministry of Home Affairs, because we have the female prisoners also who are just neglected and no one thinks about them. So we are just trying to figure out how can we do this, because I think even our current First Lady is very interested in this bit. Then over the SDGs and the universal health coverage, we started preparing a policy brief with the civil society. We want to harmonize the barriers which are there in the adolescents receiving services. In my country, you are a child up to 15 years. You've been in pediatrics. Then you can get married through local, at home. They marry them off in the villages when they're 14. Then you can have, I think, a license at a certain age to drive. You can have sex at 16 years, but you can't get married until you're 18. So we have all those. Then you can't, you need consent up to the age of 18 for anything. So we have all those policies which are not talking to each other. So we said maybe the best thing is, can we look at all these policies and see how we can harmonize them? So Ministry of Gender is helping us do that. We hope they'll reach us where we need to be reached. The human resource innovations, we've embarked on a system. You know the problem we have in our country, when you see all those, the situation analysis I showed you, it's not like we don't know what to do or we don't know where the problem is. We do, but some of the problems need human resource. You need a human being to be there. So it doesn't matter how much money you can bring to Zambia if we don't have midwives, especially, not even doctors, but midwives, nothing will work. So we are trying to come up with an innovation where we can, because we have enough trained midwives and nurses especially, but they are not employed because we don't have enough capacity in our Treasury Authority. So we are trying to come up with an innovation where we can have nurse cooperatives. Some of you understand this thing, can advise us better. The gaps at the, I wasn't given authority to talk about this, but let me talk about it. So the gaps I found at Women Deliver, I thought it would have been good if most of the sessions had taught us how to go back and domesticate these global strategies, because we've been talking about them. We understand them at that level. But how do I go to Zambia and domesticate this? Because the minister is looking at me, the PS is looking at me. Then I come from Women Deliver and have no idea how we are going to domesticate this. Thanks, please. Yeah, I think that's the last one. So this one, I just wanted to show you our roads. Most of you have been to countries like mine, but those of you who haven't, we are talking about universal health coverage and that we must reach the most vulnerable people. No one should be left behind. We are even fortunate that we have that kind of vehicle which can pass there. In other places, nothing can pass there. Thank you.
Thank you, Mary. It was good to hear that you had a lot of fun at the conference, but also that you took away a lot. and things that you've been able to apply immediately. It's quite impressive. And I was intrigued to see the various ways that you've been able to highlight collaboration across the ministries. So congratulations. I thought that was quite interesting. I wondered, there was one ministry that I was listening out for, and I was trying to get a sense of ways that you might be collaborating with the Ministry of Finance. For example, financing is so important. You know, a lot of the ministries that you were talking about were health, education, youth, community, sports. You know, I'm from the developing world also, and we sort of talk about these ministries, but we always struggle to get planning and finance to commit and engage. I wonder if you had any thoughts or comments. Have you been able to engage the Ministry of Finance, Ministry of Planning?
I think the best answer is to say it's like in a home. You have a father who's Minister of Finance, and you have 5 children who are the line ministries I was talking about. So the only way we can win Minister of Finance over is by what I was lobbying with UNFPA. Let them come for these advocacy meetings and hear what other countries are doing.
Good, thank you. So for them to be exposed and have that experience. Thank you very much. I'd like to move on to our next speaker. Alexandra Bacon is a registered midwife. She's the president of the Midwives Association of British Columbia and sits on the Canadian Association of Midwives, CAM, sits on their board. She teaches in Canada and Uganda as a clinical instructor, and she's also a steering committee member and technical advisor for CAM United Nations Population Fund, which is working towards strengthening midwifery services in South Sudan. So, Alex?
Thank you so much for having me, Roger Mark. It's such a delight and an honor to be here with you today. I'll start with a question like Susan, and that is, how many midwives do we have in the room today? Okay, 2. Excellent. That helps. I have to say this was my first Women Deliver conference, and I went in a little bit skeptical. And I came home a changed woman and a believer. So congratulations to Susan and the team. My skepticism was, will all of this hullabaloo and expense and glamour change into action? Will the dialogue continue? And the evidence is here with all of you in the room today that yes, the dialogue will continue, and yes, we are moving forward with solutions. So I'm always happy to eat my words. I am a registered midwife. I do work in Canada. I want to take a moment to give you a quick overview of our model of care there. Midwifery in Canada is a relatively new profession, ironically, in the sense of regulation and public funding. And that puts us in a unique position in the developed world to be able to partner abroad with other countries where midwifery is new in the regulated sense, in the funded sense. We have a 30-year roadmap from 0 to functional that we can share with our partners. And we do provide a continuity model of care. So we work in groups, a maximum size of 4 midwives, and we take care of 40 to 60 women per year. This is important because if you've read the Cochrane Review on models of midwifery or care, you'll know that the continuity model of care is the most supported by the evidence in terms of maximizing outcomes. And it's a piece that was one of the tools that was shared with us at the Midwifery Symposium. You'll see behind me, I was a participant in Women Deliver and the pre-conference, the 3rd Midwifery Symposium. And this year's theme was Young Midwives in the Lead. So it continued with the youth agenda that we saw at Women Deliver. The definition of youth was a little different. When you're a midwife, it's under 35, perhaps because you age prematurely. And you can see the many partners that were involved in making this symposium happen. And in particular, I want to thank UNFPA for their incredible support in making this happen, in bringing these young midwifery leaders together, and in corralling an incredible caliber of mentors to work with us over the course of the 3 days. If I reflect on Women Deliver, I would say the word that sticks with me is intersectionality. It was a conference that honored the intersectionality of women's identities and, of course, the intersectionality of the different sustainable development goals, as we've talked about, not just 3 and 5, and intersectionality of the various organizations and players that are going to see these goals become a reality. So, the Young Midwifery Leaders, we were 32 leaders from 31 countries. And it was an excellent example of investment in individuals. So if you've read the global strategy, you'll know that this is one of the key factors. And one individual can make a difference. And if you ask why midwives, I'm sure many of you know that with global standard education and regulation, midwives can meet 87% of the needs of women and children. So we really are the solution. We also happen to be terribly cost effective, which really makes us a best buy when it comes to maternal newborn child health. The problem with midwives is we're clinicians. We're on the ground and we're entrenched. We work long days and late nights. We don't get weekends, as many of you know. And what that means is that the midwifery leaders, their strengths, they were educators. They were involved in their associations, and they were advocates. But they often came to these roles because no one else wanted them. Not necessarily because they were born with a drive to be a leader. And our training is as clinicians. We are midwives. There isn't an advocacy component to your midwifery training. So how do you gain these skills? And this is where the Midwifery Symposium really shined. It addressed our weaknesses: regulation, research, policy. Many of the tools, this is the Midwifery Leaders, were things that you'll be familiar with. The Lancet series on midwifery, the Lancet series on stillbirth. The State of the World Midwifery Report is a fantastic resource. And if you're working in a particular country, I'd encourage you to pull up the report on your country. It's particularly useful for health resource planning. It looks at where you're at today and what sort of a health workforce you will have in 2030, and how are you going to bridge the gap is the question that comes up there. The State of the World Midwifery Report doesn't really apply in the Canadian context, but they do have a list of 10 essential pieces of information that all associations should have and that are relevant in developed countries. For example, in Canada, I realized that we do not have attrition data for our midwives. So that was one of the take-home pieces of action for me from the symposium. These are the countries represented. We looked at the global strategy. We, of course, reviewed the Cochrane Review. Johnson & Johnson provided some very useful workshops, one on logic modeling. Again, if you went to midwifery school, you probably didn't study logic modeling. And I know our Ministry of Health has adopted logic modeling as their new language, which means it has to be my language when I'm at the negotiation table with them next year. They also had a very useful social media strategy. I know that many of us pick up our phone, and when we have 5 minutes, we try our best to tweet and Instagram and such, but it's rather willy-nilly. And I learned about the importance of having an even tone and an even distribution of posts. Perhaps what I got most, however, from the Midwifery Symposium was connection, which was one of the keywords that Susan brought up. And it would be extremely difficult for me in any other context to connect with UNFPA, World Health Organization, JPIGO, AMREF, organizations who will be on the ground in the same place as I'm on the ground, but not necessarily talking to each other, but now we'll be talking to each other from the outset. We've got connections with the organizational supports that we need, and we have mentorship, which is huge. So each of the young midwifery leaders has been paired with a mentor. They will be tracking their media pieces, their accomplishments and actions in their home countries, and will be assessing their progress at ICM, International Confederation of Midwives Conference in Toronto in July of 2017. We did make a call to action, and you will see it published on the Lancet's blog next month if you're interested. But the call to action from the young midwifery leaders was fascinating in terms of how common the challenges were, whether or not you were in a developed or developing country. And I want to spend a moment addressing this. So, for example, one of the key challenges identified was regulation. Even in a country like Canada, we do not have midwifery regulation in all provinces and territories, which is shocking. In other places, we might have regulation, but we do not have public funding. In South Sudan, there is no regulation whatsoever and no licensure. And you can imagine the challenges that this presents. Another example of a common challenge is the challenge to implement evidence-based care. In Nepal, implementing evidence-based care might look like the primary goal there to end routine episiotomies. In Canada, it looks like normalizing birth and tackling our C-section rate. And we know that there are really only 3 interventions in Canada that have been shown to reduce the C-section rate, and that's have your baby with a midwife, use a doula, and stay out of a hospital, interestingly enough. So we need this data to be able to change policy, whether you're working in a developed or developing country. As we move on, there are some challenges that are, of course, unique. And those are the need for secure work environments and access to information technology. And this brings me to the Canadian Association of Midwives International Work. What I want to say about this international work is how much it's done for both Canadian midwives and how much I hope it will do for midwives abroad. There is so much to be gained from these kind of country-to-country partnerships. And these partnerships came out of the last ICM conference in Prague, where Canadian midwives were paired, our association, with the Tanzanian Midwives Association. And out of that was born a project, Midwives Save Lives, which started with a small grant from the Sanofi Foundation and is now being expanded to Benin, Democratic Republic of the Congo, Benin, and Ethiopia, rather, which is incredible. And we've also partnered with the UN FPA to deliver phase 2 of a project strengthening midwives in South Sudan. So Global Affairs Canada and Sweden, they're the very big players when it comes to maternal health funding in South Sudan. And we're extremely excited to be involved. The Strengthening Midwife Services in South Sudan project is a 5-year project, and it's driven by the ICM, International Confederation of Midwives, 3 pillars, which are association, regulation, and education. Of the 3 pillars, our real focus is the association piece. I can't stress that enough. We're taking on what we call a twinning approach, inspired by the ICM twinning, and it's an egalitarian approach to development. And the experts I was connected with at Women Deliver, and that's the Royal Dutch Organization of Midwives, are the experts in twinning, and they have produced both a handbook for twinning, and they're about to publish research on best practices in twinning. So another great example of connection at Women Deliver. Now, for those of you who aren't particularly familiar with South Sudan, population of about 11.5 million, the majority, 91% rural. And the outcomes are a little bit shocking. Total fertility rate, 6.7. Maternal mortality ratio, estimates vary between 750 and 2,050 per 100,000 women. Newborn mortality ratio, 37. Only 15% of births are attended by a skilled birth attendant. Less than half of women receive any antenatal care. Add to this the difficulties that have been in the news recently. For those of you who are not aware, there was a resurgence of violence. It started on the 8th, and our 2 staff members managed to get out of Juba on the 11th. I know that the Americans have sent in extra troops. Canadians have closed their embassy. So this is a resurgence of violence. It has occurred between their president and their vice president, who represent the Dinka and Nuer tribes respectively. It was this conflict that led to the civil war in 2013. There was a peace agreement signed in August of 2015. However, it's yet to be seen if they'll be able to calm the surge of violence there right now. And I want this to be an opportunity. The South Sudanese Nurse and Midwifery Association, who I've been in communication with, they wrote me and they said, please raise awareness to what's happening and please raise some morale. So I know that they're watching, and I want them to know that we're thinking about them and that we are not going to give up on them despite the conflict that's there. The conflict is having wide-reaching effects on our ability to implement this project. The government, their budget, it's hung up on dealing with the conflict. They don't have a budget to put towards healthcare. Transportation, it's not safe to go to midwifery school at the Health Science Institute. And if you graduated, it's not safe transport to practice out in the community. So it's important for us to think about particularly care in humanitarian and fragile settings. And I was extremely pleased to see the breadth of dialogue on this at the Women Deliver Symposium. And it definitely provided provided tools and contacts for us dealing with this new kind of working environment in the Canadian Association of Midwives, and working together with UNFPA to deliver services. The program will work on strengthening midwifery and nursing education, supporting task shifting and strengthening clinical practice, deploying international and national UN volunteer midwives. We're going to do a peer-to-peer pairing of 15 new Canadian graduates with 15 new South Sudanese graduates so they can offer each other support in their first years of practice, and supporting a strengthened, enabled environment for gender-sensitive maternity care. What this looks like is clinical practice guidelines coming into place, new tutor manuals, we've got to do research on operations, building the capacity of their midwifery association, which will be my particular focus as an individual, developing position statements, and then bringing on everyone together at ICM in 2017 to draw some more attention to the project. So again, what I want to come back to is how when we work together, everybody wins. And CAM's work abroad and our partnership with UNFPA is doing so much to raise the profile of midwifery in Canada, in South Sudan, in the other East African countries that we're working in. And what it's about is it's about positioning midwives as experts in maternity care. And when you're positioned as an expert and supported by the ideal partner, then you grab the attention of policymakers locally. And before we started to work abroad, it was difficult to get our foot in the door nationally. We've spent a lot of time and a lot of dollars on lobbyists attempting to achieve this goal. And if anyone had told me, I don't think I would have believed how much this would help our agendas at home as well as abroad to have this partnership in place. So I would encourage you all to take a role in partnering with other organizations and with other sister associations abroad. And if you're interested in learning more about the Young Midwifery Leaders, check out the Lancet blog to read about our action statement. Thank you.
Thank you, Alex. That was amazing. Once again, there's so much there, and the urgency of the situation of being in South Sudan and needing to respond and being innovative. And one of the things you kept referring throughout your presentation to the Lancet series and how that has been useful. And I know that this is something that we have chatted, Katie, you and I have chatted about it, but also with others. You know, very, very much we're looking for what's the evidence. We need the peer-reviewed work that guides our action. Yet this peer review process is slow, laborious, and not providing responses that we need now. You're in an emergency situation in South Sudan. You can't wait for the peer review piece. How do we bridge that gap? Are you thinking about new ways that we can bring evidence to bear on the action that we need to take now in these urgent situations? It's tough.
It is tough, and I think this is where the dialogues are so key. because we can't keep up with the evidence. And it's required that we have partners and that we bring our partners together to have the dialogue. As a clinician, I used to think dialogue was all talk and no game, I will admit. But as I move forward in this work, I realize the extreme importance of dialogue and of coming together so we can share these kind of quick solutions. The booklet Susan Papp suggested, coming up with the panorama of solutions that we can implement. We need listservs, discussion groups, any chance we have to connect with people in other areas facing conflict, other fragile settings.
So, Mary, one of the things that Alex mentioned as she was talking, Mary, she was saying that it's interesting for her to learn how engaging internationally has allowed her to advance the agenda back home in Canada. What are your thoughts? What might you have picked up in terms of lessons that you've learned from practices in developed countries that are helpful and practices that may not be helpful in your work? So could you talk a little bit about that?
Oh, it's my
Yes.
question?
Yeah.
I'm just, sorry. I'm just excited about the connection they've developed with South Sudan.
Yes.
Yeah, and I think if we all had such connections, it would be different. Because even I don't know if Genevieve Musuka was there from Zambia, because even our own midwives, sometimes they need such connections just to learn. The problem we've had in my country, because of the staffing levels which are bad, it's the attitudes of our midwives. We've tried. So I'm thinking if we can have such connections, maybe themselves can find a solution to
And
such
talk a little
problems.
bit more about these attitudes. What do you mean?
At first we thought our midwives didn't know what they're supposed to do. But then it's the same midwives when they go to private clinics, they're very nice and sweet. When they come to our public clinics, they're just rude. They throw books at the clients. Sometimes they don't explain well to the clients, and the patients are just scared of them. So when we went in and asked, they explained. It's whereby you're supposed to have maybe 4 midwives working and there's only one person, and they get tired. The environment is not that good. They don't have enough equipment. The commodities are not always there. So it gets to them, So in as much as we are trying as the government to improve their working conditions, we might not improve their salary, but we can improve their environment. I feel the connections she's talking about can help, because that's something which they should come up with for solutions. They need to find them themselves.
And are you finding, so I was quite struck that Alex mentioned that even though you may grow old prematurely as a midwife, still there are a lot of young midwives. Back home, are you working to encourage more young women to go into midwifery? Is that a strategy that you're using?
Can I ask how many medical doctors are here?
Medical doctors.
Okay. One thing you should know is the midwives will only listen to their fellow nurses and midwives. So it doesn't matter how many girls we are going to train as nurses, and they will learn all the bad attitudes until we rectify what these elderly midwives are doing. Then the new ones, when they come, they'll find good systems. So the answers lie with them.
Okay. So, Susan, it must be very rewarding to be here and hear all that has happened around Women Deliver. So congratulations again. At the same time, you're hearing some criticisms. And so there's this question, we get together, we're connecting, there's some practical tools, but is it the right model that's being presented that for us to take back and apply back home? Is it, it's impossible to try and address all of the above, but is this something that you have been thinking about at Women Deliver? Is this feedback you've had from others? Is there other feedback that you've had on the meeting that you're working towards as you aim towards the next conference?
Sure, that's a great question. I think, struck by something Mary said around the practical application of the SDGs and how when you came back, they were like, okay, we're ready, let's get started and implement the SDGs. If it were only that simple, it's not that simple. And Women Deliver, as a civil society organization, we have a role to play in convening and bringing people together and being an independent voice. But we have to remember at the end of the day that the UN really established the SDGs, and civil society certainly has a role, but it's the governments that also have a role at the local level, and it would be inappropriate for us to prescribe what the implementation looks like at the country level. What we hope to do is be able to give nuggets of inspiration and thought starters that then can help fuel conversations back at home. And we are committed to continuing to provide that guidance through tools like Deliver for Good, where we want to be able to facilitate discussions both at the regional and country level around policy coherence, policy coordination across, the cross-cutting sectors and actors that are involved. But we really see that there's also a need for UN agencies, particularly the regional commissions of the UN, who are tasked with working with their member states in those regions to make sure that the SDGs are adopted and translated into local appropriate contexts.
Great, thank you. So we'd like to open it up for you. We've allocated a lot of time for discussion, and I also wanted to just point out that immediately after the event, we have a reception for you. So there's even more time to engage and have one-on-one conversations. So my colleagues will come to you with the microphone, give your name and your affiliation, and if you can get quickly to your question. So we'll start at the back, and then we'll come to you.
Hi, my name's Fatima Nanavati. I'm actually representing the Canadian Embassy, so it was nice to hear that viewpoint. And I'm heading the Gender Equalities and International Development Department. So I was wondering, with the upcoming International Assistance Review in Canada, how you think that midwifery can be a key role in forwarding the gender equality agenda, and what policies Canada needs to change at home, or even the United States needs to change at home to make sure that they are able to benefit not only the community in Canada, but also abroad in advancing that development.
Great, thank you. Let's take another question. Yes, please. Kara, up here. Yes, up here, please. Up here. Sorry. Thank you.
Hi, I have many affiliations, but the most relevant, I'm Mindy Reiser. I evaluated the Kyrgyzstan country program of the United Nations Population Fund. Thank you, ladies. This was fantastic, every one of you. To Dr. Nambao, am I pronouncing it right? With regard to the young women, the very young women who become pregnant and have to leave school, now it sounds like you have some approach to trying to get them back after they've been pregnant, after they delivered. But what about while they still are in those 9-month periods? Are there opportunities for that to transpire? And if they come back, are there possibilities of childcare in the school? I realize that a lot of this would be focused at home, but perhaps some creative work could be done there. The United States has grappled with this for young women who are pregnant, and some schools actually have tried to do this. Might be something to look at.
Thank you. So any responses to those questions? Alex, we can start with you. So the international the systems review, gender equality and midwifery at home and abroad.
Yes. Thanks for your question, Fatima. My colleagues at the Canadian Association did enjoy going to the Canadian Embassy in Denmark to network at Women Deliver. I think that the Canadian government has a lot of work to do. Honestly, they've completely neglected the existence of midwives. And I want to touch on something that Mary said in her presentation, or in answering a question, which is midwives only listen to midwives. So while midwives might not provide the majority of care in Canada, they do in many other places in the world. The global Affairs Canada is working with. And so I think it's very important to bring midwives into the fold because we can connect with other midwives. An example of where policy needs to change at home is federal occupational classification. So along with regulation of midwifery and other professions, it's also essential to have legal acknowledgement and protection. So for example, we do have the term midwifery and midwife protected in Canada, and no one who can call themselves a midwife who is not a registered midwife. But without federal occupational classification, we can't work in federal jurisdictions. So for example, we cannot provide maternity care within the prison system without this classification. We also can't benefit from student loan forgiveness programs that are available for many of the other maternal health care professions. So that would be an example of policy change. Thanks.
Right. And what about this connection with gender equality?
Absolutely. I mean, the way that midwives connect with people has such an enormous impact on gender equality. Part of it is that we get to know the whole family. It is women-centered care and it's family-centered care. So we have an opportunity to assess and impact dynamics at the household level. We also have an opportunity to change the way that women in Canada think about their health care. We follow a principle of informed choice, and we have long visits. And a lot of women are shocked to learn that they have the right to choose whether or not to take a test, whether or not to accept a medication or procedure. They are astounded to learn that this is their right. And it's that kind of health education and equity building that midwives do on a daily basis.
Thank you. Mary?
Okay,
So how are
thank
you engaging these young women when they get pregnant during that 9-month period, childcare when they go back at school? How are you addressing those issues?
The difference now is that they can stay in school until just before they deliver, so the 9 months is taken care of. But the other thing I wanted to mention is something we are proud of as Africans is the community kind of arrangement we have. Even me, when my children are 3 months, I don't take them with me for work. I've got so many relatives at home. They look after them and I go for work. So even if there was this daycare established in schools or workplaces, really no one will need them because we have systems on how we look after the children. The thing is they can't go back immediately because there's that 3 months where they have to still stay. So maybe that's what we should be talking about is, are they given books to read? Are they given anything whilst they're at home in that 3 months? But to tell you the truth, someone would be lying if I said we needed daycare in our workplaces or we have too many dependents. We even ask them, okay, 3 of you, can you go back? I need these. And all of them will be looking after your children.
Thank you. Thank you very much. So, Susan, I was wondering the degree to which questions around financing and financial mechanisms, for example, I know we've been looking at the Global Financing Facility. How did this come up in the Women Deliver Conference?
Sure. So 2 really big focuses or foci of the Women Deliver Conference and the concurrent sessions were the global strategy for women's, children's, and adolescent health and the global financing facility. And we really kind of like to think about those things together. The global financing facility, we had a chance to brief a lot of the civil society members who were in Copenhagen with us on the financial facility. There's a lot of mystique around it. And the World Bank and some of the other partners were able to talk about what it really means for country stewardship and what country-owned financing looks like and the opportunities that it brings for accountability. And we also heard a lot at Women Deliver around the need to have civil society more engaged in those processes. Because they haven't been as engaged in the global financing facility work at the country level as they should be, recognizing the role that they have not only as implementers, but also watchdogs and accountability mechanisms.
Great, thank you. Yes. Let's have some more questions. Yes, if we can come here, please.
Rachel Wilson with Catalyst for Change. I have a comment and a question. First, a comment on the Global Financing Facility and civil society. I've worked with Results and some of the others on minimum standards for civil society engagement with the Global Financing Facility. So if people aren't familiar with that, it certainly could use more advocacy. My question is, you really did an incredible job bringing youth to the conference, even more than the last one. And the active engagement and the enthusiasm and just the sheer excitement of having them there was incredible. My question to you is, how do we build on that, and what are we doing to mobilize that? Because we ran some sessions in our Advocacy Accelerator booth with youth who were really saying, this is great, but how do we stay connected with each other? How do we really mobilize towards change? And I know that's not necessarily your responsibility to do, but I know you've also have this youth leadership component. And I wonder if you can just say a little bit more about, the potential of it really just struck me incredibly while I was there. And I would love to know how others of us can tap into that, how we can feed into that. I just feel like there's huge things that are possible, and maybe there are things that I don't know about, but I'd love to hear more about that.
Great, thank you. Let's take a few more questions. Yes.
Thank you. So Carol Miller with Palladium, the Health Policy Project. I'm just following up on Dr. Mary's comment about how do you take the SDGs and turn them into policy at home, and then Susan's response, and that maybe it's the UN who's supposed to be helping us do that. And so I'm just throwing this question out there. I know we have representatives from UNFPA and others here. Has anybody been engaged in that? Turning the SDGs into a policy for government, and can you share some of those examples of success?
Great, thank you. Yes. Yes, please.
Hi, my name's Megan Wilson. I work with a group called Medintech. We work to provide safe drinking water. But I had a question that was linked to something that Dr. Murray had said, because previously I worked in Benin for a long time, and one of the challenges we faced was getting the women themselves to recognize, the women that went to clinics, to recognize that they deserve quality care. Many women just didn't understand this. This isn't something they had never experienced, having a doctor or a midwife treat them with respect. And when they came into our clinics and this was there, it was sort of a shock. So one of the things we struggled with is, how do you raise awareness with women that they actually deserve this? And I would be very curious to hear what the situation is in Zambia, and if you struggle with that, whether or not women don't realize that they deserve this, actually.
Great, thank you. Yes, I think we had a couple more hands. Yes, please.
Hi, I'm Katie Millar from the Maternal Health Task Force. Thank you to all of our presenters. It's been a really great panel so far. I too have a comment and then a question. The comment being, it seems, and this may be a little controversial, so it's okay, but in thinking about themes of gender equality and health workforce, if you think about the medical profession and the midwifery profession, traditionally it's a male profession and a female profession. And so a lot of what I've heard as far as midwives will only talk to midwives, and maybe collaboration isn't as great as we would like to see it, is that when you have a group that's been disempowered by their community and government, you have a lot of this animosity, I think. And so I think a lot of the way forward for midwives to gain traction and truly make the difference that they can is both to be, as Alex has mentioned, respected and fairly compensated, but also that we have to accept that we need to be partners with the medical profession as well. And there's recently a paper that's come out in the Green Journal, which is the official journal of the American College of Obstetrics and Gynecology, by a physician and midwife from UCSF, talking about this very thing of that the way forward for obstetric care is collaboration. So I just wanted to make a comment on that. And then my question is for all of the panelists, and that is about innovation. And if you can talk about the focus that Women Deliver had on innovation. There was, for example, a labor ward set up there in the exhibit hall that showed innovations for low resource settings for improving maternity care, and then also different innovations as well. So thanks.
Great, thank you. So we have a number of issues, and then Gita will come to you. So innovation, how did innovation play out at the conference? I don't know if you wanted to comment on this question of health, workforce, and collaboration with the medical profession, looking at how we get women to realize that they deserve quality care. What are we seeing, and I would say folks in the audience also, in terms of SDG implementation back home? What's working, what's happening, who's thinking about that? And youth, how do we tap into the potential of youth that was so present at the conference? So Susan, maybe start with you.
Sure.
And
So
one or any of the above.
Sure. I'll start with youth, since that was the first question. So Women Deliver we don't have any formal program areas except for our Young Leaders program. And we have, the Young Leaders program consists of capacity building, training, and engagement of young leaders. We've had 3 classes of young leaders. The first 2 classes were 100 young leaders each, and now we have 200 young leaders in this new cohort. And we take them through a mini university that's a communications and advocacy training, but also issues training. And we have young leaders in 106 countries right now in this cohort. And the fellowship is a 2-year fellowship. So it's not a one and done, come to the Women Deliver conference, learn about issues affecting youth and how you have a role, but it's really an ongoing conversation and engagement with them. And in addition to the Advocacy University, we also have an engagement bureau where Women Deliver and our partners try to get young people in positions of power and have a seat at the table. So we've been successful in making sure that young people are represented on PMNCH's board, and within their country contexts, also some of the task forces around SDG implementation. And we provide backstopping and technical assistance to them when they come to us with questions. And similarly, if partners come to us and they would like to engage some of the young leaders, we're happy to be able to be a facilitator and a connector, whether that's an issue area or whether that's a geographic area. One of the things that we're exploring right now to build on our Young Leaders program is to start to think about communities of practice, because the current cohort of young leaders really focuses more on SRHR than any of the other issues. But as Women Delivers remit is expanding to reflect the SDG paradigm, we're thinking about needing to have those communities of practice to give it a little bit more structure. And then we also have a mentor and alumni network that we will be starting. So that's really how we engage young people. We think it's really, really critical. I mean, the SDG agenda is their agenda. Over and over again in Copenhagen, we talked to them and they talked to us about what meaningful youth engagement looks like and how they are the co-drivers of this agenda. They're not passive recipients of this agenda. And we think that they bring a really unique and refreshing perspective. They speak truth to power better than anyone, and they really can help reveal chronic issues that are underrepresented or unsaid in such efficiency and speed. And that's why Women Deliver is so committed to engaging young people and supporting them. Your question about SDG implementation. So I think that it really kind of revolves around sort of a multi-sector partnership where the UN agencies are leading it in conjunction with the member states, and they're supported by civil society and the private sector. And a really interesting example of where this is happening, or starting to happen rather, is in Kenya. And they have developed an SDG forum Groups like Femnet, which is a leading women's organization that works across countries in Africa, is helping to build these coalitions, interministerial coalitions, so that you're bringing water, the Minister of Water, together with agriculture and gender and health to say, okay, these are the goals. How are we going to create a coherent policy, and what's the framework look like? There are some other examples in Cambodia where this is working, but it's still very much early days. So I think that the more that we have discussions around what's working and the challenges, the better served all of the member states are going to be. And you know, that also includes the United States. We have to remember that this is a universal agenda. This is not a north-south paradigm anymore. It's changed. So that would be my comment there. And then with respect to innovation, we at Women Deliver think about innovation in 3 ways, or 2 ways. We think about, you know, hard and fast innovation, but also process innovation. And you probably heard a lot more about process innovation at this conference than you did in years past, just because we're trying to be so responsive to the new development paradigm. But we also had tools like, and examples like the Appy Hour and the Social Enterprise Challenge, and all of the really incredible stuff that happened in the exhibit space, where we are profiling innovations that really leapfrog big challenges.
Thank you. I like the answer on SDGs, and I think that's what we wanted to hear. I'll give an example of Zambia. Zambia, we are developing our National Development Plan this year. Then we move to the National Health Strategic Plan. I think this is the time where we need TA, so that we make sure what is happening in Kenya happens in our country. Because the health sector is not sleeping already over the SDGs. The other line ministries are not like that. They've moved on business as usual. We are the only ones who are worried about these SDGs. So we need, before we develop that National Development Plan, someone to bring us together and make sure we develop a proper one. My question was on whether our women even understand what they deserve. You should remember that this lack of respect for maternity care is not just because the midwives want it to be like that. It's because the system doesn't allow them to be better midwives. So we have systems in the community where we have what we call safe motherhood action groups. These are community volunteers who we orient on safe motherhood issues, and they educate the community and they sensitize the community. But we make them understand what their expectations should be. Because if you have one midwife at a health facility, you should meet them halfway. So they have an idea of what they deserve, but not everything. Because if we taught them everything, then we haven't given the environment for the midwives to give what we want them to give. It would be unfair. So I know they have an idea, but if we make the environment suitable, we'll be able to sensitize them more. So we are doing it in phases.
Thanks, Mary. That's a perfect lead-in into how I wanted to address Katie's question about collaboration. And I would say that women receiving respectful care starts with a respectful culture of training of healthcare providers. And if we do not have a respectful culture in our training, and if our training is not interdisciplinary, we will never see that respect trickle down to the level of birthing women and their families. If you're interested, Canadian Association of Midwives Conference is in October this year in Victoria, and the theme, which was my idea, was leadership and collaboration specifically led by midwives. It's imperative, but it's not going to happen unless we address the hierarchy within our healthcare systems at the hospital and facility level, and also, dare I say, and I brought this up at the Young Midwifery Leaders Symposium, at our leadership level. We have to look at the leadership of our organizations as well as in our hospitals and our educational institutions. And midwives need to move, because right now they're on the bottom of the pile. And we're not going to see change happen until that happens. And I wanted to read you a line from the Young Midwifery Leaders Declaration. We challenge all members of our healthcare teams to work as equal partners to build systems and provide evidence-based and respectful care to all women. So that was very much at the forefront of our minds. I wanted to touch on the youth agenda. I think that what we know about building leadership is it's not enough to offer a fantastic 1, 2, 3-day conference on leadership and then let go. What is much more important than the 3-day symposium is the ongoing support afterwards. It's maintaining a community, usually using an online space. I know the young midwifery leaders, their WhatsApp conversations are completely overwhelming. There's hundreds a day, but that's amazing because it's continuing. The dialogue is continuing. The Facebook dialogue is continuing. Pairing them with mentors is essential so they can learn to implement what they've learned, and accountability is essential to moving youth agenda forward to ensure that we are making good on the skills and training that we've received. The communities of practice is fantastic. Out in BC, we've started a BC Midwifery Research Network. It's been very effective at helping midwives gain skills in developing research, giving them opportunities to get involved, sitting them down with grant writers, gaining funding for their research. So the communities of practice really work, and they're an effective strategy.
Great, thank you. Guido?
Yeah, so good afternoon, everybody. I'm a member of this whole team. I'm from UNFPA. I'm the Senior Technical Advisor on Midwifery and Human Resources for Health. Thank you very much to all the speakers for the wonderful presentations. I think as UNFPA, we are partnering with all of you, Women Deliver, Zambia, and the Canadian Association of Midwives. Just to come back to your query about SDGs domestication, I think that was beautifully answered by Susan Papp. There are examples. What we find globally is the coordination mechanism, which is always lacking. You know, in the drafting of the SDGs, most of the governments were engaged. The national governments were engaged. So it is not the UN's agenda per se. It is a global agenda. Of course, the UN is leading it because it sets the tasks for the United Nations for the next 15 years. Just like the Millennium Development Goals guided our actions of all the UN agencies. So it is for the next. And now the question is coordination. At the country level, really somebody taking the lead. Some countries it's working very well, but some countries really, even the UN needs to step up its task. But really, I think it's a two-way thing. If you find that the UN agencies, nobody is really coming forward, but you know the governments can also hold them responsible, and vice versa. Somebody has to come and set up the mechanism, but it presents a great opportunity right now. To use the national strategies and to make sure, because the targets are pretty difficult. I mean, you're talking about ending preventable maternal and neonatal mortality in the next 15 years. So it's really, I mean, if actions are not taken now, we won't achieve those. Just to come back to the symposium, UNFPA has been supporting midwifery as one of the key drivers in addressing maternal and newborn health. We started with about 8 countries. Today, the midwifery program is in over 100 countries. And now taking it to the SDGs, we found, because we have a lot of learning to go by, so we've decided to invest more in young midwifery leaders and champions, to find champions, because the policy agenda, we still need to invest a lot. So we've come a long way. We are addressing education, association, regulatory mechanisms, but really finding the champions who can deal, who can advocate at the ministry level, etc. That's really key. And going ahead again, looking at regulations, a title for midwives, proper, who is a midwife, so addressing those things, looking at innovations, not just process innovations, not just innovations per se, but innovations that lead to impact. And impact, to get impact out of an innovation, you need implementation. So it's a three-way cycle. It's innovation, product innovation, process innovation. You have to look at the whole rigmarole of innovations, and so that is another area of focus. I like that there was a lot of mention about, which is quite interesting for me because I've been dealing a lot with midwives. I'm not a midwife, but I've dealt with thousands of midwives, and I found your comment really poignant, Mary, when you said midwives talk to midwives, because there is some element of truth. And I think it is to do with all this professional, I think the professional collaboration. One forgets that, you need teams of healthcare professionals. A midwife by herself cannot do much. You do need doctors. Hence, in the South Sudan project, we are looking not just at midwifery, we are also looking at task shifting. You need clinical officers. There are 8 doctors in South Sudan. I've just come from a 5-week mission from South Sudan. I just came back 10 days ago, 15 days ago, just before violence broke out again. There are 8 doctors in the country. Out of that, 4 doctors are sitting in the Ministry of Health. That means there are 4 doctors in the country. Currently, when we started the program, we had 8 fully trained midwives. Today, we have about 300 fully trained midwives as per global standards. But still, the ratio of midwives to population is 1 per 10,000. So it's abysmal. I mean, when we are talking about capacities, frankly, it was an eye-opener being in South Sudan. You don't know where to start. You just don't know where to start. There's no capacity anywhere. The Ministry of Health, I mean, I'm just talking from my heart now. The Ministry of Health, we met with the Director General of Reproductive Health, who is paid by UNFPA, who's a retiree who's paid by UNFPA. The Director General of Education, his salary is less than $100 per month, and he hasn't been paid for 5 months. And later, just after a meeting, we came to know that he's living in the civilian camp, which is within the UN compound. There are 56,000 people currently living in the protection of civilian camps within the UN compound. And and the Director General, who gets about less than $100 a month, who was staying till very recently in that camp. I'm sure he's come back. He had left the camp, but he may have come back. So the conditions, I mean, where do we talk about how can the Ministry of Health move if those are the conditions? What kind of incentive do they have to do anything? To get a letter signed, because we are also going to be investing in, we have 4 health sciences institutes. We want to scale it up to 7. We want to know about the management of those health sciences institute. We couldn't get a letter signed for over a month to figure out, who's going to do what. There are no roads still in the country. There are 2 roads in Juba, in the capital city. So, I mean, I'm just giving a little bit of a reality check that the conditions are sometimes it's very New York and Washington, this is more of a academic dialogue. But we do need to be aware of what exactly is the reality on the ground. I mean, the South Sudan Association of Midwives, we've been desperately trying to set up an office for them for the past 1.5 years. The materials have arrived, but we've not succeeded, despite best efforts, to set up the containers, of where they can operate from. Plus conflict. So it's an onerous task ahead of you. I just wanted to say, in Zambia, we are working very closely with the Midwifery Association, and we look forward to working. I mean, there's a lot of funding that is coming to Zambia. We'd be more than delighted to work with you, to help you, to support you in any which way we can. And we are with you in this big task ahead the next 15 years.
Thank you, Gita. Let's, any other comments, quick questions? Yes, please.
Thank you for that reality check. Having lived in Ethiopia 8 years, I know what some of those challenges are. I did want to mention there's nobody here from the White Ribbon Alliance for Safe Motherhood, but they are our partner as part of Health Policy Plus and have been doing really great work in respectful maternity care. And so I know that they've had policies adopted in Nepal, and they're working with Malawi and a number of other countries. So if you're not familiar with that, that is one nice inroad into bridging that gap between respect, and it should go beyond nurse midwives, of course, and midwives, but all care should be respectful.
Great. Any other final comments? So I think we've covered quite a bit today. We've gotten a sense of the challenge and the opportunities that have been presented around convening with Women Deliver. I think one of the key takeaways for us was this point on integration, the intersectionality, and recognizing that if we want to move forward, that it is more complicated than SDG 3, and what that means is we think about moving that agenda forward, and what does that mean for collaboration, partnerships across different sectors, across different ministries, and at different scales. So once again, a reaffirmation of that important point. I think we had a lot of good conversations around the role of innovation. We talked about product innovation, process innovation, how does that lead to impact, and what does that mean for implementation. We talked about the difficulty of delivering these services in conflict, emergency, humanitarian settings, and needing to innovate in that context, but really dealing with very onerous challenges, and at the same time needing evidence to inform all of our actions. But the typical peer review process is slow and doesn't always give us that evidence. So there's some need for innovation in thinking of those processes also. I think we also covered the point of innovation can't happen in a vacuum, that there's a need for some regulation and support. I think for Canada, we heard that this means having the federal occupation classification for midwives, for example, and what those opportunities provide within that context. Interesting to hear things coming out of Women Deliver, such as the Appy Hour, and sort of the opportunity to harness innovation in that context. So we talked about integration, we talked about innovation, we talked about the role of different partners. We talked about the regional commissions of the UN and what it meant for SDG implications and application back home. We had a series of tools, the Deliver for Good tools. We talked about the role of the private sector and making the investment case for a variety of sectors and what that means. And we talked about the importance of youth and youth engagement and leadership. We talked about collaboration with the medical profession. We talked about emerging leaders and mentoring and how do we help to foster that. So a lot of conversation about youth engagement, partnership, different roles, and how we move that forward, and how this helps us respond to the gaps and challenges. In particular, we spoke about challenges for domesticating the SDG agenda. We recognized that, very interesting, I think, to hear that there isn't an advocacy component to a midwifery training, nor logic modeling. There are things that practically you have to learn to advance the agenda, to deal with these gaps. And this leads to the question of advocacy and the role of advocacy. You know, you said this was an advocacy conference. This is not a technical conference. But, you know, we heard about an advocacy university. We heard about an advocacy accelerator booth. All of these things that are happening, but also helping these women who are receiving the services to understand that there are opportunities for them to advocate for themselves too, to understand the level of care that they should be getting and what that looks like, but also thinking of which approaches are culturally appropriate, what fits in a specific context, and how we are able to mentor and develop and appreciate that. So, wow. You guys, this is amazing. So please join me in thanking Alex, Mary, and Susan. This was awesome. Thank you. So this it was webcast live. It has been video recorded. Will be video archived. You can go back and look at it. It will be on newsecuritybeat.org. We will also write a blog summary of the discussion. So you'll have a summary of the discussion, and all the PowerPoint presentations will also be on the site. So newsecuritybeat.org for the video archive, a summary of the discussion, all the PowerPoint presentations. So thank you for engaging, a really, really meaningful conversation. And please stay for further dialogue and networking with the reception. My colleagues will guide you. It's just outside the door. So thank you very much.